Hello, my name is Julia Lange and I'm a nursing student practicing at Heartland Healthcare Center. Today I'm going to tell you about a patient I assessed on June 11th. Patient is a 72-year-old Caucasian female who has been married for 53 years. She graduated from high school and attended beauty school for 2 years before dropping out and marrying her current husband. On May 11th, she was taken to the emergency room at U of M Hospital due to a family concern after she had had three falls in 3 days at her place of residence. She was admitted to Heartland Healthcare Center on May 11th with gait instability and peripheral neuropathy of the left leg, believed to be caused by her type 2 diabetes. History of present illness. At this time, while on pain medication, she is experiencing a pain level of 4 out of 10 in intensity and 9 out of 10 without pain medication in her lower lumbar region. She describes her pain as radiating downwards into her anterior thighs. Patient states that the onset of lower back pain began 2 years ago and has increasingly worsened throughout the past year. Patient has little feeling in her left leg and experiences most of the anesthesia and paresthesia during activity, such as getting in and out of a motor vehicle or walking. Her lumbar pain is worse in the morning, but is alleviated when cushioned by a pillow and sitting in an orthopedic position. Patient has used pharmacological and non-pharmacological interventions, such as pain medication and heating pads to alleviate pain, with little success. Patient stated that her chronic back pain and instability while walking has limited her daily living activities, complaining that she does not walk much anymore. During her stay at Heartland, she has become very gloomy about her situation. Vitals. Vital signs are stable. Temperature, 98.2 degrees Fahrenheit taken orally. Blood pressure, 142/62. Heart rate, 67, and respiratory rate, 18. Past medical history. Patient was diagnosed with type 2 diabetes 10 years ago. She has a history of hypertension, hyperlipidemia, and GERD, gastroesophageal reflux disease. All immunizations are up to date, and patient is allergic to penicillin and sulfa. Past hospitalizations and surgeries. Patient's tonsils and gallbladder have been removed. Current medications. Patient is on numerous medications for hypertension and high cholesterol, as well as multiple pain medications for her chronic back pain. Patient is also on Claritin, metformin type 2, PPI, proton pump inhibitors for GERD, and amitriptyline HCl tablet for her recently developed depression. Functional assessment. Patient denies alcohol, tobacco, and drug use. Patient asserts she smoked only a period of 2 years during high school. Patient did not have a regular exercise regimen before attendance into Heartland due to her chronic back pain and impaired gait. She now attends daily physical therapy sessions provided at Heartland. She states that she sleeps and eats regularly, denies any nutritional problems. Patient also states that at home she drank coffee or soda once per day. Psychosocial. Prior to hospital admittance, patient lived with her husband and 2 of her grandchildren, ages 17 and 14, in Ypsilanti, Michigan. Patient denies any perceived stressors and considers herself a spiritual person, but states she does not attend church regularly. Patient is a mother of 3 grown children, 1 son and 2 daughters. She currently has 6 female grandchildren, all of various ages. Patient states that her entire family lived in Ypsilanti and she receives much love and support from them. Family history. Patient's father died of lymphoma cancer, her mother died of Alzheimer's disease 2 years prior, and her single female sibling died of MS. Review of systems, peripheral vascular. Due to patient's diagnosis of diabetes mellitus and peripheral neuropathy, it is imperative to perform regular peripheral vascular assessments. Patient states persistent and chronic lower back pain for 2 years that radiates to her anterior thighs. Pain is most severe during activity such as walking. She explains that she has little feeling in her left leg, accompanied with occasional tingling and numbing sensations. Patient denies any unnatural hair loss to extremities and believes she has never had any varicose veins or blood clots. Upon examination, patient's legs had no signs of varicosities, but were pallid. Hair distribution was sparse and in thin patches along calves. Bilateral edema was found on calves. Ankles and feet. Bilaterally, the carotid and brachial pulses were +2. Bilateral brachial, radial, popliteal, posterior tibial, and dorsalis pedis were +1. Upon palpation of lower extremities, no varicosities or tenderness were found. Calves were mildly warm in temperature with signs of bilateral non-pitting edema. Poor capillary refill was found in fingers, taking 4 seconds. System 2, respiratory. Due to patients' lack of mobility, admittance into the hospital, and type 2 diabetes, it is critical to perform regular respiratory exams in order to be proactive against disease and infection. Patient denies shortness of breath, pain, and/or wheezing during breathing. She also denies any history of pneumonia, bronchitis, upper respiratory infections, and asthma. Patient verbalized mild allergies during spring, which she alleviates by taking Claritin. Upon examination, patient's breathing pattern looked relaxed and non-labored while seated. Patient displayed no distress, but a regulatory rate of breathing and depth. Her thorax was symmetric with an AP transverse diameter of 1 to 2, with no signs of visible injury. Upon palpation, her trachea was sturdy and in alignment. Posterior chest expansion was even bilaterally. Posterior tactile fremitus displayed no signs of consolidation. Upon posterior palpation of ribs and thorax, there were no signs of protrusions or crepitus. Upon auscultation of all lung fields anteriorly, laterally, and posteriorly, normal bronchial, bronchiovascular, and vascular sounds were heard. Vocal fremitus signs of bronchophony, egophony, and whispered pectoriloquy showed no signs of consolidation. Pertinent system number 1, integument. Patient was diagnosed with type 2 diabetes 10 years ago. According to a recent article published in Biomed Research International, diabetes mellitus predisposes a patient to ulcers and skin deterioration due to the lack of circulation and sensation in the lower extremities. A diabetic foot syndrome is very common, yet a very severe complication, leaving wounds that may never properly heal, thus decreasing the quality of life and increasing the risk of lower extremity amputation. Therefore, the need for regular and preemptive integumentary exams is imperative. Pertinent system number 2. Due to my patient's age and family history of dementia, with her mother dying of Alzheimer's disease, her obesity and diabetes, it is critical that a neurological assessment and a mental status exam be performed regularly. According to an article published in the American Journal of Neuroradiology, Alzheimer's disease is the most common cause of disability in the elderly population, affecting 1 in 8 individuals ages 65 and older. Most Alzheimer's disease cases are late onset, and they are typically influenced by genetic and environmental factors. My patient's obesity, metabolic disease of diabetes, and hyperlipidemia also put her at a heightened risk of developing Alzheimer's disease. According to this research, based on twin studies, inheritance in Alzheimer's disease plays a role in nearly 80% of all cases. Therefore, a regular method of neurological testing and assessment is critical so that any detection of dementia can be caught early.